Now we must know certain terminologies in cardiophysiology. So it is not only important to know what is stroke volume, what is end-diastolic volume, but we must know the all physiological variant which are controlling stroke volume, cardiac output, and all the variables. Because in the exam nowadays they are not going to ask you simple what is the definition. You must know physiologically what are the parameters that are controlling those variables. So this topic is actually very conceptual. I'm telling you, this is one of the most conceptual topic you need to understand with a great depth. So let us discuss number one, what is stroke volume? It's very simple. Although it is a conceptual, but these are very simple. Amount of blood ejected in one stroke. Amount of blood ejected in one stroke is called as stroke volume. And simply we can say it is end diastolic volume minus end systolic volume. So end diastolic volume, which is actually I will discuss in detail, it is preload. End diastolic volume is actually what? Preload. It is amount of blood. It is amount of blood, you can say, before contraction start. It is amount of blood before contraction start, or you can say amount of blood after diastole or relaxation, complete relaxation, total blood before contraction start. It is preload. It is preload. So I hope you will not forget end diastolic volume. What is end systolic volume? Okay, end systolic volume. It is the amount of blood remaining after contraction, which remain after contraction. Now, if contraction is more, and systolic volume will be less. Yes or no? If contraction is very slow, okay, and systolic volume will be more. So, lesser is the end systolic volume. Now, this concept is very important. This will help you a lot in so many understanding. Lesser is end systolic volume, better will be contractility. This whole topic is actually concept based and lot of question can be solved. So try to understand. End systolic volume is the amount of blood after the contraction is over. Better is the contraction, lesser amount of blood will left. If full contraction 100%, okay, no blood will be left. If 80%, only 20% will be left. So like that, lesser is the end systolic volume, better is the contractility, or you can say better is the inotropic action. It is called as inotropy, increase inotropy or positive inotropy. On the other hand, more is the end systolic volume. More is the end systolic volume. Okay. Lesser is the contractility. Lesser is the contractility and lesser will be inotropy. Inotropic action will be negative. Second concept. Now you can see in this formula, lesser is the end systolic volume. Okay. More will be stroke volume. More is the stroke volume, amount of blood ejected, amount of blood we are already having minus what is left after the contraction, and systolic volume. So lesser is the end systolic volume, more will be the stroke volume. On other hand, more is the end systolic volume, lesser will be stroke volume. I hope this whole page is clear. This concept is absolutely clear, there is no doubt. And diastolic volume, amount of blood which is before contraction, or you can say it is a preload. Preload means amount of blood before contraction is called as preload, or after relaxation, complete filling, ventricular filling. And systolic volume is the blood remaining after the contraction. So lesser is the end systolic volume, better will be stroke volume. More is the end systolic volume, lesser will be stroke volume. This much is clear, doctor? Now, in the same setting, we can discuss Frank-Starling law. What is Frank? I will discuss it again, but because we are in the mood of understanding and diastolic volume, okay, so force of contraction proportional to what? Stroke volume will be proportional to end diastolic volume, or you can say simply preload under physiological limit. Only up to certain limit, stroke volume will be increased by preload. So more is the preload, more is the force of contraction. more will be the stroke volume. It is called as simply Frank. This topic we have discussed in the skeletal also. There we have discussed force of contraction was proportional to the initial length under physiological limit. It is the same law in the setting of skeletal muscle, and this is the same law in the setting of cardiac. I hope this page is absolutely clear. Okay, take notes of this, try to write it so you will remember that. Okay, now what is ejection fraction, doctor? Ejection fraction is the amount of blood ejected upon stroke volume upon end diastolic volume. Are you getting my point or not? Or you can say end diastolic volume minus end systolic volume is your stroke volume upon end diastolic volume. Clear? Suppose 80% is ejected out of 100 ml. Okay, so ejection fraction will be how much? 80%. Suppose I have 120 ml of blood before contraction, and after contraction, suppose only 40 ml is left. Okay, so upon 120 was end diastolic, so it will be how much? 80 upon 120 into 100. Okay, it will be around, what is the answer? How much percentage? 7 to the 14, no, 6, 72, again 80, so 66.6%. So in this condition, it can be, you can say 67% is the ejection fraction. I've given you one example only. So ejection fraction, nowadays, it is used a lot in clinical, left ventricular ejection fraction. It is the index of ventricular contractility in systolic heart failure. Usually, it is normal in diastolic heart. It is decreased. It is the index of ventricular contractility. So in systolic heart failure, it is decreased. It is decreased in systolic heart failure and normal in diastolic heart failure. Of course, in systolic heart failure, problem is with the stroke volume, problem is with the ejection fraction. Normally, it should be more than 60%, because if it is very, very less, we say heart failure, systolic heart failure. So ejection fraction is equal to, once again, ejection fraction is equal to stroke volume upon end diastolic volume. Stroke volume is end diastolic volume minus end systolic volume upon end diastolic volume, or simply we can say it is an index of ventricular contractility. You are comparing how much is gone out of how much was there. This comparison is actually index of ventricular contractility. So I hope end diastolic volume, end systolic volume, stroke volume, preload, okay, and now ejection fraction, these terms are clear for you. Now cardiac output, cardiac output. But before cardiac output, I will say mean arterial pressure or blood pressure. Mean arterial pressure is the average pressure, is equal to cardiac output into total peripheral resistance. I will come to this point, don't worry. So now I'm talking about cardiac output. Cardiac output is responsible for systolic blood pressure. TPR is responsible for diastolic BP, concept number 1. Only if you understand this much, then we will come to cardiac output. So blood pressure is what? Whenever we say mean arterial pressure, it is the average pressure. So average pressure is what? Cardiac output into total peripheral resistance. And cardiac output is depending on systolic BP. So if cardiac output is more, systolic BP is more. Are you getting me? If peripheral resistance is more, okay, then diastolic BP is more. That is why when we have diastolic hypertension, we give vasodilator, we have to work on resistance, we give prazosin, all those things I will discuss, don't worry. So now taking the first component of BP, and that is cardiac output, Q. It is equal to stroke volume into heart rate. Already we discussed about the stroke volume, amount of blood ejected in one stroke, into heart rate is cardiac output. Usually it can be 5.2 liter per minute. Depending on the heart rate and the stroke volume of the person, it can be around 5 liter. Sometimes we need to know what is the best method to control, to measure cardiac output. Sometimes they ask in the examination which is the best method, and answer will be fixed principle. Okay, so cardiac output is equal to stroke volume and heart rate. Stroke volume depends on, in the later chapter I will tell you, I'm just making a foundation of that. It depends on preload, it depends on afterload, it depends on contractility. 3 parameters, which I will discuss after this page. Okay, this is clear. The whole chapter is clear. BP is cardiac output into TPR. Cardiac output is stroke volume into heart rate. Stroke volume depends on preload, afterload, and contractility. Clear? So now cardiac output can be measured by, what is the answer? Fixed principle. And what is the fixed principle? Cardiac output is equal to rate of oxygen consumption upon arterial oxygen content minus venous oxygen content. So in the exam, they can ask you this formula also, or else they can give you the values. So you have to put the values and you have to solve, because nowadays they have calculator in the exam. And even if they don't have calculator, they will give you the values, you can solve orally. Okay, only those values they will give. So cardiac output can be calculated by fixed principle. Nowadays, it is the best principle. We can do Doppler and MRI also, but this is for physiology. Now, notes. In the notes, I will discuss the questions that can be asked regarding this formula. Like they ask you regarding the exercise physiology, effect of exercise on the heart. We have discussed effect of exercise on the respiratory system. So these are actually integrated topic. Nowadays, they have given MBBS curriculum. So peculiarly, they have given these topics. So they are preparing MCQ from those topics. So in early stage of exercise, as we start exercise, what will increase heart rate? Okay. So this cardiac output is maintained by what? Increase in the heart rate and increase in the stroke volume. So when we are doing exercise, we need more blood to the muscles. Okay. So more blood to the muscles can be given only if there is more cardiac output. And in the early stage of exercise, it can be increased by both tachycardia, we have increased heart rate, as well as initially even stroke volume is increased. Okay. But in the later stages, you are exercising for a long time, cardiac output is only maintained by increasing the heart rate, because stroke volume will reach a plateau. After that, you cannot increase the stroke volume. That is why athletes have better stroke volume than us, because they keep on exercising. So with regular exercise, automatically their stroke volume is more, so their heart rate is always less. That is why they have physiological bradycardia. Those who are doing exercise, or those who are doing yoga, okay, they have beautiful 60, 62, and lesser is the resting heart rate, lesser is your pulse, better is your heart. Nowadays, it is one of the indicator in the cardiac physiology and medical science. Okay, they are taking as an indicator. So why? Because lesser is the heart rate, you will have better stroke volume, because cardiac output is usually fixed. Your body has a fixed cardiac output around approximately. And if those person who are having less stroke volume, automatically they have tachycardia. So they are obese and they will be having decreased stroke volume. Why? Because they have increased tachycardia. Increase in the heart rate is actually compensation for less stroke volume. If we have less stroke volume, every tissue of the heart needs blood. So what can we do? Only one thing we can do. What is that, doctor? That is, we have to increase the heart rate. And if heart rate is less, okay, it means we are athlete, we are doing regular exercise, we are active, it is good. Okay. So in later stage, the only way is to increase heart rate. Diastole is shortened. This we have discussed in the earlier also, that with tachycardia, diastole will be shortened. Okay, with increased tachycardia, and this will decrease diastolic filling time. So automatically, heart is getting blood when during diastole only, and diastole is already decreasing by tachycardia. So when there is a tachycardia, automatically diastole will decrease, and diastole will decrease, so it will shorten what? Diastolic filling time. So automatically heart is not getting enough blood, the stroke volume become less, cardiac output become less. So if we are not athlete and we are keep on doing exercise for the first time for 1 hour, 2 hour, then automatically stroke volume become less, cardiac output less. You must have heard. So you must have heard that a lot of people are doing tachycardia. They're on treadmill and they are doing, walking, and they are running like anything, and they met with heart attack, because stroke volume become less, cardiac output become less. So it is not good for them. For the first time, we should not do much exercise. If you are a regular athlete, only then we should increase the time of exercise. I hope this concept is clear, because nowadays they're twisting and turning the question from exercise, and only by this simple formula, cardiac output equal to stroke volume into heart rate, it is easily understood. Clear? Now, sometimes this is from your Ganong only. They ask you what are the factor which can increase or decrease cardiac output. So when you are sleeping or there is a moderate increase in the temperature, there is no change. Cardiac output can increase in anxiety, excitement, eating, exercise, increased temperature of the environment. More, it is not moderate, it is more than moderate. Pregnancy, epinephrine. Or it can be decreased by sitting or standing from the lying position because of the pooling of blood in the legs. And kidney amputation. Kidney amputation, it will decrease because of increase in TPR will cause decrease in cardiac output. So please at least remember these examples from Ganong. Sometimes they can ask you from this table. Now, what is pulse pressure? Pulse pressure is equal to systolic BP minus diastolic BP. Why I am telling this? Because when we need to look for mean arterial pressure. Just now I told you mean arterial pressure is equal to cardiac output into total peripheral resistance. Okay, like that also you can calculate. Other method is that it is the average of BP. Mean arterial pressure is the average pressure in the aorta. Average pressure, average blood pressure. If someone says his BP is 130, so he's talking about systolic or diastolic. When someone is going one value, it is always mean arterial. If they say 130/60 or like that, it is systolic or diastolic. So until they say systolic or diastolic and they are giving you one value, it is a mean arterial pressure. Okay, and mean arterial pressure is equal to, you can see here, diastolic BP plus one third of pulse pressure. What is pulse pressure, doctor? Systolic minus diastolic. Or else you can write like that, 2 diastolic BP plus systolic BP upon 3. Sometimes they will ask you in this way also. You must know both the way. And one of the most important thing is that mean arterial pressure is the indicator of afterload. This is a indicator of afterload. Clear? Why afterload? See, preload we have discussed, it was amount of blood before contraction. That was end-diastolic volume. Suppose you want to open a door. Okay, so amount of pressure you are pulling, it is preload. Amount of blood you are having, it is a preload. But someone is standing on opposite side and they are not allowing you to open. There's a movie, I think Padmavati only. They are trying to open the door and lot of people were there. They were just opposing that. So the amount of blood or amount of pressure, that is mean arterial pressure, will oppose that opening of the valve. So mean arterial pressure is called as afterload. Mean arterial pressure is called as afterload. Clear? So now pulse pressure. What is pulse pressure? Systolic minus diastolic. Pulse pressure. Nowadays, a lot of questions are asked directly from pulse pressure. And believe me, if you know this, you can understand so many of concepts. Pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. So pulse pressure, what is pulse pressure? Systole minus diastole, is proportional to the stroke volume upon arterial compliance. Now you can understand a lot of MCQ in your books. Okay. For example, they can ask you increase in the pulse pressure. So in all those conditions, either they have increased stroke volume or they have less aortic compliance, like aortic regurgitation. If aortic regurgitation is there, blood will go back in the ventricle, stroke volume will increase and diastolic volume will increase. So they will increase pulse pressure. Aortic stiffening. Why? Because aortic stiffening is decreasing the compliance. So this will again increase the pulse pressure. Isolated systolic hypertension in the older adult. Obstructive sleep apnea will increase the sympathetic tone. High output state like anemia, hyperthyroid, they are going to increase stroke volume, so increase pulse pressure, and exercise will transiently increase pulse pressure. Once again, what are the conditions that are increasing pulse pressure? Aortic regurgitation because of stroke volume, aortic stiffening because of compliance, obstructive sleep apnea because of sympathetic tone, they will increase stroke volume, high output state like anemia, hyperthyroid, these all will have increased pulse pressure. So if you know this formula, you can know all these options. Now it is decreased in aortic stenosis. That was aortic stiffening. Aortic stiffening is different than aortic stenosis. Sometimes both options will be there, and if you don't know this concept, you cannot answer. So aortic stenosis, stroke volume will be less, pulse pressure will be less. But if aortic stiffening is there, means compliance is less, so pulse pressure will be more. Cardiogenic shock, stroke volume is less, pulse pressure is less. Cardiac tamponade, advanced heart failure, in all those conditions, whenever there is a decrease in the stroke volume, automatically pulse pressure will be less. I hope this page is remembered to you. This topic which I am discussing now is very important. And just increase the speed and see this video for 2 or 3 or 4 times. Okay, you can increase the speed after one video, after just seeing the video, after concepts are developed, you can increase the speed and see it again and again. Now, cardiac output variables. Cardiac output is stroke volume into heart rate. We have discussed stroke volume is affected by preload, afterload, contractility. This we have discussed. And we will go in more detail now. Like increased stroke volume with increased contractility, increase preload, but decrease afterload. If contractility is more, stroke volume depends on preload, afterload, contractility. Preload more, stroke volume more. Contractility more, stroke volume more. But afterload, if it is less, only then stroke volume will be more. What is afterload? Mean arterial pressure. Clear? Okay, now we will discuss. So stroke work. What is stroke work? It is a work done by ventricle to eject the stroke volume. So amount of blood ejected is stroke volume. Amount of blood ejected in one stroke is stroke volume, and amount of work done to eject that stroke volume is called as stroke work. And a failing heart has decreased stroke volume, okay, systolic and or sometimes diastolic also. Okay, now contractility and stroke volume. Because of contractility, stroke volume will also increase. Why? In catecholamine stimulation via beta 1 receptor. Via beta 1 receptor. What is beta 1 receptor? If you remember, in the electrical activity of heart chapter, in the cardiac muscle, it is G stimulatory. It was increasing cyclic AMP. It was increasing cyclic AMP. And you know, the funny current was cyclic AMP dependence. So that was increasing the heart rate. Okay, that was increasing the heart rate. So that will increase the stroke volume and contractility. Number one. Do you remember this or not? If you don't remember, please go back to the same chapter. So according to the heart, in the heart, there was beta 1 receptor and M2 receptor. Beta 1 was sympathetic, M2 was parasympathetic. Beta 1 was stimulated by catecholamines. They will increase cyclic AMP, they will increase heart rate, they will increase what? Stroke volume and contractility. Clear? In phospholamban, what happened? This is your T tubule. This is sarcoplasmic reticulum. Okay. And calcium goes inside by Sarca. Okay. Inside it is going by Sarca. Clear? Now, Sarca is inhibited by whom? Phospholamban. Please don't forget, this is very important concept. And catecholamines like norepinephrine and all, they are causing phosphorylation of phospholamban. It's a very, very important point. Listen carefully. Sarca, which is causing calcium back in sarcoplasmic reticulum, so that relaxation can happen. Because relaxation is also an active process. And this Sarca is usually inhibited by whom? Phospholamban. So that relaxation should be very, very slow. But when there are catecholamines, norepinephrine, what they will cause? Phosphorylation of phospholamban. And phospholamban usually was inhibiting. Now this inhibition will be inhibited. So calcium ATPase in the Sarca will be active. It will cause more calcium storage in the sarcoplasmic reticulum. So more relaxation, and more relaxation is called as positive lucitropy. Positive lucitropy. And when there is a more calcium storage, okay, more force of contraction, so it will cause positive inotropy. Positive inotropy. That is contractility. So contractility can be increased by both. By increasing heart rate from beta 1, number one. When beta 1, when there is more and more heart rate, okay, that will not allowing calcium to go back. So we will get more calcium and more force of contraction. So up to certain limit, contractility can be increased by tachycardia, by positive chronotropy. It is called as positive. Now everything which we have discussed there is used now. Every concept is important. So positive chronotropy, increase in the heart rate. When there is increase in the heart rate, you are not giving enough time to relax. So accumulated calcium will cause more force of contraction. So positive chronotropy will cause positive inotropy. What is positive inotropy? Of course, contractility. Is this clear, doctor? Now, in the second condition, catecholamines are also causing more and more calcium in the reticulum. It is called as positive lucitropy. Increase ventricular relaxation due to more accumulation of the calcium. Why? Because, listen once again, phospholamban is inhibiting Sarca, the calcium ATPase pump, and catecholamines causes phosphorylation of phospholamban, okay, activating the Sarca. So more calcium goes in the sarcoplasmic reticulum, so more force of contraction will be there. So positive chronotropy is causing positive inotropy, and positive Lucy is also causing positive inotropy. I hope this concept is absolutely clear. It's a very, very important concept, doctor. Okay. Now, this I have discussed. Activated protein kinase A will cause more calcium phosphorylation, more calcium entry, calcium induced calcium release, more intracellular calcium will cause more force of contraction, contractility. Now, one more concept. So we can understand that if there is more contractility, it is because of catecholamine. Catecholamine, if act on beta 1 receptor, can cause increase in the heart rate, can cause more calcium accumulation, and can cause more contractility, called as positive inotropy. So chronotropy can cause inotropy, and even there is a lucitropy, it can also cause positive inotropy. Now, next point. We know about digoxin. Digoxin blocks sodium potassium pump. So how it is increasing contractility? Suppose this is our heart, and on one side there is sodium potassium pump, on other side there is sodium calcium exchanger. So if we block this sodium potassium channel, digoxin blocks sodium potassium channel, so calcium will not go out, because sodium potassium channel is giving energy to sodium calcium exchanger. So now calcium will not go out, so intracellularly calcium will increase. Okay, because of intracellular increase in the sodium, decrease in the exchanger, it will increase intracellular calcium, and this intracellular calcium will cause increased contractility. I hope these all concepts are clear. So we have discussed how digoxin is increasing contractility. We have discussed how catecholamines, by causing positive chronotropy, by causing positive lucitropy, are increasing contractility. Now contractility and stroke volume can be decreased by, okay, how they can be decreased? Number one, by beta 1 blockade. Of course, if you give beta 1 blocker like atenolol, metoprolol, and all those things, it will decrease cyclic EMP, decrease heart rate, decrease stroke volume, and decrease contractility. Heart failure with systolic function, acidosis, hypoxia, hypercapnia, even calcium channel blockers, these can also decrease contractility as well as stroke volume. Preload is approximated by ventricular and diastolic volume. We know what is preload and diastolic volume, and it depends on venous tone and circulating blood volume. More is the blood volume, more is the force of contraction. It is called as preload. And sometimes venous vasodilator like nitroglycerin can also decrease preload. Preload is the amount of blood in the ventricle before contraction. If we have given venous vasodilator, okay, though preload will be decreased, so automatically force of contraction will be decreased, stroke volume will be decreased. Okay, so this is how decrease in the preload happens due to venous vasodilator like nitroglycerin. Afterload, we have discussed, it is approximated by mean arterial pressure. Mean arterial pressure is the average pressure in the aorta. Okay, this is working against opening of aortic valve. So more is the wall tension per Laplace law. Laplace law is P is equal to 2T by R. Okay, P is equal to 2T by R. So more is the wall tension. Laplace law, increased pressure will increase after load. Increased pressure will increase after load. And left ventricular compensate for increase after load by thickening. So if there is a more after load, ventricle will contract in a more, more, what to say, more work done will be there. So they have to contract more and more, so there will be wall thickening. This has been also asked. During hypertension, why we are having left ventricle hypertrophy? The reason is that whenever there is increase in the mean arterial pressure, or due to any other condition, whenever there is increase in the mean arterial pressure, left ventricle have to compensate for increase after load by thickening. So there will be increase in the wall of what? Left ventricle. There will be left ventricle hypertrophy. Only then you can decrease wall stress, because as per Laplace law, increase in the wall tension per Laplace law will increase pressure more and more, and that can increase afterload. That is why sometimes due to some stenosis also there can be increase in the afterload. So the main concept which you have to remember after this whole discussion is that who is the indicator of preload and diastolic volume? Who is the indicator of afterload? It is mean arterial pressure. Clear? Even if you forget about the Laplace law and all, only 3 points you have to remember. For your exam purpose, indicator of preload is and diastolic volume. Indicator of afterload is mean arterial pressure. And if there is a more and more afterload, because of this, there will be wall thickening. Only this much is sufficient for your exam. It is a very detailed chapter actually given in books. But this is the minimum concept as a doctor, which is enough to solve your physiology question as well as pharma question and medical question if they are asking the same concept again and again. Arteriovasodilator, venous vasodilator, by decreasing the preload. Clear? Nitroglycerin. This is a wonderful question which is integrated with your pharma. Arterial vasodilator like hydralazines, they are decreasing after load. On the other hand, see how beautifully they have explained everything. Preload decreased by vasodilator, nitroglycerin. Afterload decreased by hydrogen. And if you want to decrease both preload and afterload, give ACE inhibitor and ARB. Angiotensin receptor blocker. Olmesartan, telmisartan, agilsartans, they are blocking angiotensin too. And angiotensin has so many roles. They cause contraction of veins. They releases, ADH, aldosterone, absorb sodium, thirst. There are plenty of things we have discussed in the RAS. So if you directly block angiotensin 2 receptor, you can decrease not only preload but also afterload. And already we have discussed if there is chronic hypertension. Now this is a summary. If there is a chronic hypertension, there will be increase in the mean arterial pressure, and that will cause left ventricle hypertrophy. It is a very common finding. So those who are having hypertension chronically and they are not taking medicines, okay, if you do the X-ray or if you do ECG also, you will get left ventricular hypertrophy. Now, sometimes they ask you cardiac oxygen demand, in which condition it will be increased, in which condition it will be decreased. It's very simple if you understand the concept. Myocardial oxygen demand is going to increase by number one, contractility. If there is a more contractility, very simple, automatically oxygen demand will increase. Or if heart is contracting against increase after load due to hypertension, due to any other condition. So in all the condition, whenever there is increase in the after load, automatically oxygen demand will increase. Number third, if there is more tachycardia, there is more heart rate, or you can say positive chronotropy, okay, it has to pump more and more and more again and again, so you need more oxygen again. Fourth, if there is increase in the diameter of the ventricle because of the increased wall tension, again they need more oxygen. So please do remember, plenty of time all these four has been asked in your exam. Okay, one fact is there, it is only a fact, nothing to do with the oxygen demand. Coronary sinus contain most deoxygenated blood in the body. So who contains most deoxygenated blood in the body? Coronary sinus. Okay. Now we have discussed Frank-Starling law. If you increase end-diastolic volume, stroke volume can be increased. This is which law? Frank-Starling. This is Frank-Starling law. Okay. This is normal. And if you are increasing force of contraction, it will on this side. If you're decreasing, this will be on this side. Now, force of contraction is proportional to end diastolic length of cardiac muscle fiber or preload, which law? Frank-Starling law. Increase contractility. We have discussed so many factors, like for example, with catecholamines or with positive inotropes like dobutamine, milrinone or digoxin, they will shift curve towards the left. Decrease contractility with the loss of function of myocardium, like myocardial infarction, beta blockers, acutely if you are giving, or non-dihydropyridine calcium blocker, heart failure. You can see in the heart failure, it's very, very less, extreme left. But in the heart failure, when you have given positive inotropes, it's shifted on this side. This is normal. And this is, if you are doing exercise and you have better stroke volume, it will go further left. So sometimes they will give this graph and they will ask you, what is A, what is B, what is C, what is D, like that. So you can say C can be normal, A can be heart failure, and from A to B, it is increasing the force of contraction by using some positive inotropes, by using digoxin, like that. So this is a very simple curve based on the concept. Thanks, doctor. Thanks a lot.